Hello there and welcome back to part 2 of Frailty. I'm Dr. Sarah Bohn. This important medical concern needs to be monitored for and needs intervention. In part 1, we discussed some of the typical changes that occur with natural aging process to affect a person's nutrition, appetite, strength, balance, and recovery. We talked about how medications may be needed, but they could also interfere with a person's best function. We also talked about how important it is to support a patient and keep them healthy so they don't get admitted to a hospital. Today we're going to go over some considerations such as mental health, needing assistance, evaluation, management, and disease state modification. How each of these can impact frailty, evaluation for frailty, and some interventions. So thanks for being here and sharing this channel with someone that might need some help or some information. Mental health issues are an important consideration in frail patients. This may be separate or in conjunction with another medical issue. Mental health issues can adversely be affected by medications as well as by disease processes. Whether a medication is being used to treat a disease process or treat a mental health issue, there can be unwanted side effects. The balance between risk and benefit is often delicate. Many neurologic processes can certainly affect mental health, with nearly every type of dementia or cognitive impairment process being included in that group. Parkinson's, multiple sclerosis, peripheral neuropathy are just a few of the disease processes that can affect a person's brain and also impact their mood and mental health. If the person has had a stroke in the past, their mental health is likely going to be affected as well. Heck, just being sick will affect a person's mental health. So there's a catch-22 between frailty and risk for anxiety or depression, or even the risk of delirium. Delirium in a hospitalized patient, even when there's not cognitive impairment, can occur because of the many things that we talked about in the prior video. Delirium represents its own insult to someone and to their brain, especially if they're frail. It is a separate and very worrisome process for an individual to develop delirium. Frail patients are at a higher risk for delirium, and patients that have delirium are at a higher risk for frailty. Other consequences associated with frailty can include issues with self-care, which often adversely affects a person's mental health. Issues with mobility and independence, which also can be an important impacting factor for mental health. Patients with frailty have a higher utilization of the healthcare system and maybe more expense or burden on their finances, and they can experience an increase in hospitalizations, often with longer lengths of stay, which again increases the risk for frailty to worsen and can impact their mental health. When there are more readmissions, each hospitalization increases risks. It is super important for patients to have the care they need and receive it in the environment of their own home and the support that they require to keep them out of the hospital. As we talked about in the last video, being in the hospital exposes to significant risk. There's a video here on the channel that goes into a lot more detail about a hospital isn't as safe as what you might think. There's some really important information there if you haven't seen that video. Next, a frail person is more likely to require help, possibly custodial care. Some patients living in an independent living building will see progression naturally over time to an assisted living situation being needed, and so forth, to eventually needing full custodial care. This might be a nursing home or possibly a skilled nursing facility. Which of these is needed is often determined by the number and severity of illnesses that a patient has, and that directly affects their level of need. And of course, all of these have different levels of costs and expenses. Patients in custodial care are typically in better health than those needing skilled nursing care. And we've talked about life expectancy after admission to a skilled facility in another video, and the honest truth about nursing home life and life expectancy or skilled care are very upsetting. When a person needs skilled nursing care, it does indicate that the patient's lifespan is nearing its final chapter. As you can see, the intricacies of frailty are many, and they're all worrisome. It's a multifaceted problem, and it's extremely important. Finally, we're ready to talk a bit about the evaluation for determining if someone is frail. In the first video segment, we reviewed a rapid screener. This by no means is the only type of screening that is done. A thorough evaluation of frailty can be done by several methods. Probably the best one is having a geriatric assessment completed. This process is reviewed in another video, but in a nutshell, this is an interdisciplinary evaluation of medical, functional, psychological, and social needs while looking at access to those services that are needed by the patient. The evaluation is quite involved. Several disciplines will participate in the assessment process, and it can take days or even weeks to complete, as there needs to be coordination between those multiple services. Therapists, physicians, psychology, and social workers are typically the minimal personnel that are involved. This evaluation sounds and is wonderful. However, few people, patients and their loved ones, seem to want this type of assessment when they learn about what it really is. I've often wondered about the factors contributing to this reluctance. I'm certain some of it, cost, time, and travel commitment, are factors, but I also wonder if some of this might be hesitancy to say what is actually happening out loud. Some people don't like telling because that admission of information can make it more real to them. I've had patients and families tell me, "I don't want to know. Hearing the truth is too painful." Where I work now, we offer this service, and we arrange for several of these specialties to evaluate that patient on the same day, and sometimes we're able to coordinate the evaluation so the several specialists will meet with the patient at the same time. It's a prolonged and involved evaluation and visit. The patient must bring a collaborative source of information, whether that's a family member, friend, or loved one. One of those is requested, and the healthcare surrogate is also highly recommended. Now it's time to talk a little bit about management of frailty. It will likely be disappointing to learn that there's not a cure for frailty and the treatments are limited. Even when reversed, it is likely to return. There are treatments, though. You're not likely to want to hear about the first and best treatment because the treatment of frailty begins with therapy, aka also known as exercise. Physical and occupational therapy are often the mainstay types of treatment that's recommended for patients with frailty. Physical therapy has their own evaluation for frailty, and of course, strength and balance are a big part of their testing. Therapy will use a special device for measuring bilateral grip strength. Walking speed is evaluated because it's a specific predictor for frailty, and it's used as a common measure. Activity level, weight loss of 10 pounds or more in a year by the patient's own report, as well as the patient's report of exhaustion, again, are other indicators that are looked at. The time to get up and go test is another commonly used evaluation by therapy. This is a simple and reliable test that evaluates a patient's ability to stand from a seated position in a chair, walk 10 feet, turn around, and sit down in the chair. Results of this should be less than 10 seconds. That's normal. This simple test is a good indicator for fall risk of a person. Falls increase by age. A person between the ages of 65 and 75 has nearly a 20% chance of fall in a year. This increases to nearly 30% for patients between the ages of 75 and 85, and for folks over the age of 85, their increased risk is just slightly over 35% in a year. A phrase I say to patients all the time is safety first. You may think that what you're going through right now is bad, but if you fall or if there's a trauma or an injury, you're going to make a bad situation even worse. Exercise is listed as the first and often best intervention for treatment of frailty. This often creates a dilemma as patients say they want therapy and they love the idea of therapy until they find out the therapist isn't going to be there for every single session doing things with them every time. It's going to provide them access to the therapy, provide education and supervision, but mostly they're going to evaluate them and then give them homework. The work of the patient has to be done by the patient. So it's work, W-O-R-K. That's the dirty four-letter word here. Homework has to be done, and it must be done on a regular basis, and sometimes that's even daily. Practicing doing the assignment will hopefully lead to that improvement. I say that because sometimes even with the best intention and tremendous effort, the improvement is not reaching the goal that the patient and loved one are wanting. Exercise is typically multimodal. Aerobic and resistance type with flexibility are all important, as well as balance. If we had to prioritize these, typically resistance training does take the first seat, but I think balance and flexibility are extremely important as well. Exercise takes lots and lots of hours of independent home practice being done on a regular basis. It might be 10 minutes every other day the first few days, then 10 minutes every day, then possibly 20 minutes a few days per week, and then maybe graduating to the next several days of more time and into weeks and into months. So exercise is work, and there are many things that a person can do on their own without formal therapy to strengthen themselves. Getting up out of a chair without using your hands on the arms of the chair or table to push off sounds like a simple activity, yet it's not insignificant. So sitting on the floor to put your shoes on in the morning so you can learn how to get up off of the floor. Sometimes people actually need the therapist to teach them a better way to get up off of the floor. These maneuvers all require strength, balance, and gait. The therapist will provide the recommendations, do regular evaluations, provide supervision to ensure that correct technique is being done with that regular follow-up. And as with anything else, the better the patient does, often the more difficult the homework assignments become. Additionally, the patient is likely to require some assistance, particularly at the beginning. The help needed is often unskilled, and that means that a loved one or friend is likely going to be enlisted. Someone is going to need to assist the patient. The patient and therapist cannot do it all, and help is often necessary. Occupational therapy will evaluate a patient's home environment, their fall risks from environmental factors such as clutter or obstacles, furniture, lighting fixtures, lighting of the room. They will look at the person's footwear as well as helping the patient learn safer ways to improve self-care. There may be other intervention evaluations as well, as there are multiple different types of therapy. More than just physical and occupational therapy, but other special therapists may be needed. There's a special therapist for incontinence that may be needed, or possibly pulmonary rehab therapy. There are many interventions and teachings to assist the patient and family with learning new adaptive ways to approach everyday life and function. This can be difficult, as sometimes it means breaking old habits and letting go of the way things have always been done. That's often hard, because of a method that we've used to complete a task is now been entrenched in our brain, and we're trying to change that. But it also represents something else that's difficult for us to accept, and that is that change is necessary, and change is the one thing that remains the same. The next step in treatment of frailty kind of brings us full circle, back to the other disease states that contributed to the frail condition to begin with. We need to consider the other illnesses that the patient has and what might be modifiable. For a lot of folks, the patient, their medical team, and family have already taken measures that are reasonable to treat the illness or to minimize the effects of a disease process. It's sobering if you're listening to a clinician and they tell you that the first line treatment did not work, so they're moving on to the second line. And it's frightening if you're alert when being told that the second line treatment was not successful, because we use the best treatment first. We use the second best treatment next. All of this represents disease progression. Not just at this point, but at multiple intervals, it's important to have all those medications that the patient has on their list reviewed. There are times when a disease has arrived at a point and when the patient's illness has progressed to a degree that the medication that once helped or served a purpose is no longer adding benefit. As we go through our health journey of life, we tend to collect doctors, nurses, therapists, and often many medications. Sometimes too many medications. For people that have all these medications and they're not going away, sometimes we've passed that patient from one physician to another, and yet the medications remain the same. Sometimes patients are inadvertently told, "You will always need this medication," or they might be informed, "This is a must-have for you for your ongoing treatment." There's a time in our health, though, that a medication or treatment is no longer warranted. Some medications just are not meant to be used indefinitely. Patients and families might be reluctant to give up medications because they realize it represents that disease progression sign, and that can be difficult to accept. When the time has come that a medication is no longer able to serve its intended purpose, it really needs to be looked at closely to consider if it should be decreased or possibly discontinued altogether. Personally, I really like to discontinue unnecessary medications. Both the patient and their clinician must be in agreement as to how and when that deprescribing is to be handled. Even if not putting a person at risk, additional medications do add to pill burden and can contribute to the risk for drug interactions. Consider this. As we age, absorption of medications remains the same, but metabolism, distribution, clearance, and drug sensitivity, as well as excretion, can all decrease. I find the task of summarizing frailty to be a difficult one because there are so many elements that influence this. Frailty is often thought of as solely a geriatric syndrome, and certainly elderly are at risk. Older women are at a higher risk than men. Patients that are isolated are more frail. Some disease processes contribute more than others. Diseases that limit activity, such as arthritis, heart and lung diseases, often weigh more heavily on a person. There is a typical and natural progression of decreasing function. Loss of the physiological reserve across the body systems does occur with normal aging. So yes, that's true, often age-related, but not always for a person that's got frailty. For some, frailty is disease-related. The disease itself may be placing tremendous burden on the patient, causing significant decline of strength, skill, balance, and resilience. And for some, that can happen pretty rapidly. For others, it has more to do with the length of time that a person has had a particular disease process and the toll over time that that disease is progressive. Sometimes patients are doing all they possibly can, and pushing them harder to get better just isn't going to help them. For some folks, there can be a component of nutrition-related issues that sometimes a person is not able to control. Appetite and digestion play important roles here, as well as medications. The neurohormonal axis doesn't function as precisely as we age, and that adds another element to the problem. Medications used to treat disease processes can become unsuitable, with potential to actually cause harm and place a person at higher risk. Thus, medications need to periodically be analyzed and reviewed to determine if that risk-benefit balance is still favorable. Frailty places patients at risk for decline and harm, as weakness occurs with increased possibility for fall and risk for trauma is increasing. Injury can further contribute to decline. For some, once this chain reaction has begun, it may be difficult to reverse or even pause. For others, it's completely impossible to stop. For a frail patient, there's higher vulnerability and elevated risk for worrisome health events and even death. Falls, infection, weight loss, adverse effect from medication, hospitalization, general overall decline of health, especially with aging. Increased risk of hospitalization, and associated with that is the increased risk for death. To an extent, frailty can be managed with support and work. Some frailty can be slowed, possibly reversed, at least for a period of time. So frailty, like many other diseases and syndromes, should actively be looked for and managed. My quest is to help provide information because knowledge is power. People that prepare for the future, they're aware of their health and their options, they make choices that mean the most to them. Making informed decisions timely and not out of fear is important. Life is treasured. Life is finite. We want to live the best we can as long as we can, living life to the fullest each and every day. Please communicate with your healthcare team and with your family, openly and honestly. We need to promote kindness and help one another on our journey, living each day we are given as optimally as possible. Thanks for being here for this. I really appreciate you all. I'll be back soon with more information on another topic. Kind comments are welcome. Bye now.